I'd like to invite up next Dr. Tony Sidawy, who will talk about the vascular's role in the vascular verification process. He's been intimately involved in this and has been a real champion of quality care for vascular surgery. Dr. Sidawy.
Thank you, Dr. Eagleton, and really thank you for dedicating the Crawford session for this program, which is a new program for SVS, and it's really, we believe, it's an excellent program, and it'll be good to just talk about it and have people see what we put together over the last few years, as Dr. Ko said. Also, I would like to thank Dr. Ko and the college staff for their excellent work with us. It took us 5 years to put this program together. We started thinking about a similar program about 25 years ago, a few of us here in the society, and we couldn't put it together for multiple reasons. But now, with the collaboration with the college and the infrastructure of the college and the knowledge of the college and quality, as you've seen, we were able to do so. So hopefully, most of you will take advantage of it. We have nothing to disclose. Payment reform, what's happening now around here in the United States is payment for physician services are moving from payment for service, fee for service, to a more and more complex, but towards value and quality. And now we are actually in the area where we are getting close to full capitation. So in summary, actually, payment for our services are moving from payment for volume to payment for value. But what's value in healthcare? Well, value is quality divided by cost. So to increase the value, which the government wants to do and the insurance company wants to do, either you have to improve quality or decrease cost, or actually, preferably, do both of them. But the fundamental question is who defines quality and value? And that's an extremely important question, because if we do not, as specialists in vascular disease, then there are gonna be multiple entities that would love to define them for us. You've got the governmental agencies, insurance companies, corporations, on and on and on and on. So, as I mentioned, we've been working on this for a long time, and in 2015, I became a regent of the American College of Surgeons, and I started serving on the committee that Dr. Cliff Ko heads, and that's the quality committee. It's called DROPSI. And I got a front seat position to see how sophisticated the college program. So right away it came to my mind, well, we've been trying to put together a program for vascular surgery. How about if we put it in collaboration with the American College of Surgeons? And you've seen from Dr. Ko's presentation the number of programs that the college has. So basically, the SVS and ACS decided to collaborate about putting together such a program. Now, the college has an unbelievable infrastructure, unbelievably knowledgeable people led by Dr. Ko. They house these programs, so they're able to do it, which one of the obstacles that when we were trying to put program alone, we couldn't figure out who was gonna house the program. And obviously, the SVS can offer what we always wanted to do, as you've seen from Dr. Eagleton's slide, in our mission, is to improve the quality of vascular care. But most importantly, actually, the SVS already has a registry program, which every one of these programs needs a registry. And if we didn't have it, then we needed to put together a registry. So we have VQI in addition to the targeted NSQIP database. And also we have the clinical practice guidelines used to put the standards together. This program was put based on the 4 guiding principles that the college had. You put the standards that are backed with research. You put the right infrastructure based on those standards, and then you collect data, and then you have a verification visit by external review. But the issue is what kind of model we wanted to use. So we thought about, well, how about based on complexity of the procedure performed. Arterial versus venous. Should we have one for inpatient, one for outpatient? Should we have one for vascular surgery, open, and one for endovascular? We really took a long time thinking. At the end, the decision was made is to base a program on all these things. So we came up, I'm not putting this up for you to read it, but basically we came up with 2 levels for inpatient and 1 level for outpatient. And the 2 levels for outpatient, one is called comprehensive inpatient, and one is called verified inpatient. And then we have a verified outpatient program. And the only difference between the comprehensive inpatient and the verified is just the thoracic and thoracoabdominal work. That will move you to comprehensive if you're doing them. We put the standards together. It took a long time, but thankfully the college staff is expert on really putting them in the right language and the right organization. But we divide them into the 9 components of the episode of care, as you see on the screen. Again, I'm not asking you to read the slide, but these are 49 standards divided by the 9 episodes of care. And every standard is described and the requirement from the center, what to have for that particular standard. And once we put all these standards together, then we wanted to test them. So we went to do a beta testing of the standard. We chose 4 inpatients and 4 outpatient pilot sites. And as you see here, they are all kind of potpourri of different sites, academic, non-academic, all that. And the verification process starts with a pre-visit questionnaire, what we call PRQ. And also, so it include a virtual site visit because those site visits were done during COVID. So we could not do them in person. We did them virtually. And actually, virtual worked extremely well. So the pre-review questionnaire is completed. And then the program chose 50 to 60 actual cases that we chose 20 of them to discuss with the faculty there to see how they think and what are the areas, that clinical areas that they're having issues with. And then the verification visit is with everyone that's included in the leadership. Starts with the CEO, COO, CMO, CNO, all the way down to anesthesia, nursing, the whole thing. So a day and a half for the inpatient and a day for the outpatient. And we review the selected cases that we chose 20 of them, and then we do visit summation. Within 6 to 8 weeks, we send them actually the report. This is the first one, the inaugural visit, Albany. As you see here, Dr. Clem Darling, who's going to speak to you in the top middle picture. All 5 others were asking him questions. So we're not like ganging up on Clem, but let me tell you, he's... he can take it, and he would do that very, very well. So here we are. In that particular one, Dr. David Hoyt, and you see Dr. Ko is there, and I am down there where that red arrow is like a mini-me among everyone else. So here's the lessons we learned from this program. Is centers reported improvement of their processes just by preparing for the visit. They reported leverage for resources from the administration. It's extremely important. We were able to use information to refine the standards before we made them public, and many other actually benefits. Until today, the activities since the launch, we've had in the inpatient program, since it launched in March of 2023, there have been 1,367 downloads of the inpatient manual. Since the outpatient program launched in September of 2023, it's been 292 downloads. Since the inpatient, so there are currently 19 active VVP applications, all inpatient. 6 of these sites have already opened PRQ. We have now since I prepared the slide, actually we have 5 sites that are ready for the site visit. You've seen this. We had to put that program together. We had a very complex structure, but now that we have it, as you see here, we really have a simplified structure, steering committee, inpatient committee, outpatient committee. The inpatient led by Dr. Darling, and Bill Schuss leads the outpatient, and you will hear from them after this. Thank you very much for your attention.